Assalamu alaikum. My name is Dr. Syed Mashud Ahmad, and this is a lecture in the series of Knowledge for Life project of Humanity First. I am board certified in internal medicine, and I was fortunate enough to serve in Africa from 1994 to 1999 under Nusra Jahan. I'm currently a medical specialist in Thai Heart Institute and board certified in internal medicine, American Board of Internal Medicine. Slides, please. Slide here. So, topic for today is type 1 diabetes mellitus and its management. A little bit about pathogenesis and epidemiology, quick slides, and that will show us, that will put us forward to the management. Type 1A diabetes mellitus result from autoimmune destruction of insulin producing beta cells in islet of Langerhans. This process occurs in genetically susceptible subjects or patients, triggered by one or more environmental agents. Genetic marker for type 1 diabetes is present from birth. Immune markers are detected after onset of the autoimmune process. Metabolic markers can be detected with sensitive test once enough beta cells damage has occurred, but before the onset of symptoms. This long latent period is a reflection of the large number of functioning beta cells that must be lost. So here we can see the time and course of type 1 diabetes. So you can see on the top, one or more environmental triggers the in genetic susceptible patients, and then there are long subclinical in which beta cells dysfunctions take place. Once a critical beta cell mass has been destroyed, the clinical type 1 diabetes mellitus develops. Pathogenesis. Type 1B diabetes refer to no autoimmune islet cell destruction. So there are type 1A and type 1B. So B, there is no autoimmune reaction. Polymorphism of multiple genes are known to influence the risk of type 1A diabetes. HLA-DQ alpha or HLA-D beta or HLA-DR. There are a number of the pancreatic beta cells that play important roles in the initiation or progression of the autoimmune islets. These include glutamic acid, decarboxylase, insulin, and zinc transporter. Environmental factors that may affect risk include pregnancy-related perinatal influences, viruses, and ingestion of milk and cereals. Diabetes affects more than 170 million people in the world. 10% of these patients are diabetes patients have type 1 diabetes. Cardiovascular morbidity in diabetes patient is 2 to 4 times greater than non-diabetics. In epidemiology, type 1 diabetes mellitus is one of the most common chronic disease of the childhood. It accounts for 2/3 of all cases in diabetes in patients younger than 19 years of age. Worldwide incidence ranging from 0.1 to 65. So that's a wide margin we have here, depending on different ethnic group and different countries. So from 0.1 to 65 per 1,000 children younger than 15. So this graph is giving you incidence of diabetes in youth of the age group from 0 to 4, 3 to 9, 10 to 14, 15 to 9. The thing to point out here is that type 1 diabetes is common, very common up to the age of 14 versus type 2 diabetes. And when you go between age group 15 to 19 and onwards, even in adult population, then type 2 diabetes become more common. Another slide showing the prevalence of type 1 and type 2 diabetes in children, in adolescents, in the United States, in different ethnic groups. So you can see the white community, white patients, they are more prone to type 1 as well as type 2 diabetes. And then come black and Hispanic. This is slide from United States of America. So, but in black, we can find out that a significant number of type 1 diabetes um, over the year of from 2001 to 2009. Prediction of type 1 diabetes. These tests which are specifically seeing the genetic markers, they are only in trial phase. So doctors should know it because there are research going on, and in the lay media, patient hear about them and then ask the doctors, and doctors should actually be aware of all these tests which are there but in trial phase. They are not done routinely. In research setting, following approach may be useful. Test individual at risk for type 1 diabetes progression from GAD65 and IA2 autoantibodies. If they are confirmed, tests for insulin, zinc transporter, and islet antibodies can be done. And first phase of insulin response to glucose should be determined. Genetic typing is also done for high-risk subjects who are eligible for the trial. Presentation. Childhood diabetes usually present with a classic sign and symptom resulting from hyperglycemia, including polyuria, polydipsia, weight loss, and lethargy. Ketoacidosis is often the initial presentation of type 1 diabetes, especially in the children younger than 6 years of age. And children of all ages with poor access to healthcare, and that's relevant to Africa. A diagnosis of diabetes based upon any one of 4 detected abnormality of glucose metabolism. So that we have to pay a lot of attention on these 4. Number 1 is fasting plasma glucose equal or more than 126 milligram per deciliter on at least 2 occasions. Number 2, symptom of hyperglycemia and plasma glucose more than 200, plasma glucose more than or equal to 200, measured 2 hours after standard glucose load on oral glucose tolerance test, hemoglobin A1C equal to or more than 6.5. This is more relevant in type 2 diabetes. Type 1 diabetes often can be distinguished from other causes of diabetes such as type 2 by clinical presentation and laboratory studies. For example, there are 4 factors in clinical part of it as body habitus. The patient with type 2 diabetes are usually obese in contrast to children with type 1 diabetes, and are usually not obese, and in contrast, patients with type 1 diabetes are not obese and often have a recent history of weight loss. Age. Patients with type 2 diabetes generally present after the onset of puberty, whereas those with type 1 diabetes often present at an earlier age. About 45% of children with type 1 diabetes present before 10 years of age. Contrast, type 2 is presented after 19 years of age. So, insulin resistance. Patients with type 2 diabetes frequently have acanthosis nigricans, a sign of insulin resistance. hypertension, dyslipidemia, and polycystic ovary syndrome in girls. These findings are less likely in children with type 1 diabetes. For example, 50 to 90% of patients with type 2 diabetes have acanthosis nigricans versus 12 in type 1 diabetes. Family history: up to 10% of patients with type 1 diabetes have an affected close relative versus 75 to 90% of type 2 have affected close relative. So family history is more relevant, is make more sense in type 2 diabetes. Diagnosis: not usually required. These lab tests, which we talked about earlier, are not usually required, which I have mentioned, so I'm not going to repeat them here. In routine care of or in routine diagnosis of type 1 diabetes patient. So ADA criteria, I have mentioned them previously. Overview of type 1 diabetes management. So why should we treat type 1 diabetes? We should treat it because we want life. There is going to be in the management part of it is lifetime insulin therapy, lifetime modification, which include diet and exercise. Are we doing okay? Desired outcome: reduce risk for microvascular and macrovascular complication. That's the desired outcome. That's what we want to get. Which is the other one is reduce mortality, achieve glycemic control, and improve quality of life. Intensive treatment goal in part of it is intensive diabetic therapy is recommended for type 1. You have to treat it intensively because insulin is required here, which include coordination of meal and diet and activity with physiological insulin replacement, which involve frequently monitoring of blood glucose level with goal of achieving glycemic control as close to diabetic range as safely possible. Hemoglobin A1C should be 7 or less. Type of insulin: the primary therapy for type 1 diabetes is insulin replacement, of course, because there are no beta cell to produce insulin. Four basic forms of insulin are there: rapid acting, short acting, intermediate acting, and long acting. So these are various type of insulin. Rapid acting, Lispro, aspartate, glucine. Onset of action is 5 to 15 minutes. Peak effect 45 to 75 minutes, and duration of action 2 to 4 hours. Regular about 30 minutes. Onset of action 2 to 4 hours. Peak effect and duration of action is 5 to 8 hours. So then there are intermediate acting, which is NPH, and you can see the onset and the peak effect and duration of that. Insulin glargine is a long acting insulin, and its onset of action is about 2 hours, and there is no peak, so that's good, because for long acting we don't want to have a peak and hypoglycemia. So we have to have a steady basal rate of the insulin release. And the duration of action you can see is very nice, 20 to 24. One of my favorite insulin, which I give to my diabetic patient. Insulin replacement goal is to provide insulin therapy basal level of insulin. So when we think about a pancreas, how it works. So pancreas always is secreting some little amount of insulin in blood, and that is actually what we call a basal level of insulin. Once we eat, for example, having breakfast, then there is spike of insulin, and which control the carbohydrates and move them intracellularly. So basal, so we want to mimic as much physiological normal physiology, and that's a good way to treat um, type 1 diabetes. So let's move on to see how this is where intermediate and short acting insulin is being used. So you can, I would say rapid acting insulin. And so you can see there are two peaks given twice, NPH and Lente. And this is regular, the Aspart, which is a short acting insulin given 3 times with glargine, which has a steady basal effect for 24 hours. So 3 meals, 3 time insulin being given. Of course, insulin comes with some adverse effect in certain patients. So hypoglycemia is top of this list. So hypoglycemia treatments, usually when the patient gets a low reading of hypoglycemia, it's very important that he should not over-treat it. The rule of treating hypoglycemia if patient is conscious and have a low level of blood sugar is rule of 15. That is 15 gram of carbohydrate every 15 minutes until blood glucose goes greater than 70. So sometime in our patient in panic, they overtreat it and then throw all the control away. Of course, when patient is unconscious, then he has to be taken, treated emergently with glucagon injection or IV glucose. So there are certain foods which if somebody goes, and we have to teach our patient if they go into hypoglycemia, they should take those. The top list is food that we will provide 10 gram, will provide 10 gram of carbs. So half cup of orange juice, for example, is good. By taking like a liter of orange juice will not solve anything. Sugar, 2 tablespoons of or 2 cubes, or glucose tablet, 2 to 4 tablets. Apple juice, 1/3 cup. So by just giving this, this amount will correct the hypoglycemia if the patient is able to take um, uh, uh, by mouth. Foods to avoid: ice cream, candy bars, cookies and cakes. Complex carbs slowly, those complex carbs which are slowly absorbed. If an unconscious, I have mentioned, it has to be treated urgently. So we got the insulin replacement part of our therapy, and then there is nutritional therapy. So there are various nutrients which has to be given to recommended amount to our patients. So carbohydrate goal is 50 to 60% of the total calories. Proteins 15 to 20% of the total calories. Total fats 25 to 30 of the total calories. And then we have to break those fats into saturated fats, which should be less than 10% of total calories, and monounsaturated fats up to 20% of the total calories. Cholesterol less than 300 milligram per deciliter, and total calories based on age. Total calories are all based on age, sex, and BMI of the patient. Exercise recommendation: American Diabetic Association advises 30 to 60 minutes of aerobic activity 3 to 4 times a week. Surgeon General recommends 30 minutes of moderate physical activity on most days of the week. So this last part of my presentation, I would like to highlight how to give the insulin injection correctly and how to teach our patient to give the insulin injection correctly. So injectable, I will go through some pictures. This is Dr. Nadi from Thyroid Institute. He is going to walk us through in pictures how um, the insulin is given. So first of all, we have to gather all the necessary equipment, and then, in these equipment we have alcoholic pads, we have insulin regular, which is clear insulin, and NPH, which is, you see that it's whitish, milky insulin. Then we have this insulin syringe, and of course a bag of a box of gloves. So milky insulin has to be, shaken gently, rotated between the palm of the hand, which Dr. Nadi is illustrating here in this slide. And then when we are going to fill our syringe with insulin, first it has to be filled to the required amount with air. And then this air has to be injected in the vial, and then it will be easier to draw the required amount. For example, 12 units are being drawn, so it's easier to draw insulin when you inject air into the vial. So we pinch the area, and remember, for regular or short-acting insulin, it's better to use abdomen, and for long-acting, we can use thigh. So long-acting absorbs slowly, and abdomen, the insulin actually absorbs quickly. So you can see Dr. Nadi have a big pinch from the abdomen area, and he's cleaning it, and then he is injecting perpendicularly. So it's very important you go right angle into that area, and once you are going to inject, you have to release a little bit, so the insulin can get subcutaneously. So the pressure has to be released. And the other thing is, if there is air in the syringe, it's going to be painful. So make sure there is no air in the syringe. Jazakumullah wa ahsan jazak for listening to our podcast.